So lovely to have everybody. I'm going to start formally now. It's great to open up with Dr. Jess Kaufman, who's a research fellow in vaccine uptake at the Murdoch Children's Research Institute. He specialises in looking at uptake in pregnant women and refugees, amongst others. Importantly, she's on the steering committee for the collaboration on social science and immunisation. She's got a lot of important things to say, and it's great to have her opening up the conference today. And over to you, Jessica.
Thanks very much, Robert. And thanks everyone for having me today and for making time to join this session. I know it's a pretty hectic time out there right now. Today I'm going to be talking about the COVID vaccines in general and the community response to them. So as Robert said, I work in the vaccine uptake group, the Murdoch Children's Research Institute, and we really focus on vaccine acceptance and vaccine communication and understanding the drivers of vaccine uptake. So this has been a really particularly interesting and challenging period for us and our research. So just as an outline for my talk, I will start with just sort of a brief overview of COVID vaccine acceptance and hesitancy, and then I'll go into the findings from a recent study that we led from MCRI, which was supported by the Victorian government, looking really at COVID vaccine preparedness in the key priority groups, phase 1A and 1B. And then at the end of the talk, I'll have a little bit of time to talk about some of the next steps and our recommendations from that study, and also some opportunities for the future and for expanding some of the things we've learned potentially into other adult vaccines. So we know, we're, I guess, painfully aware that the vaccine rollout is not going as quickly as we maybe hoped or was maybe initially planned. And you would be forgiven for thinking that that's due to primarily vaccine hesitancy. Certainly, the media has spoken quite substantially about vaccine hesitancy and concerns in different groups, and it's been really highlighted. And it is an issue, and it is something that we're focusing on, certainly. But it is also, not everything is due to hesitancy, and I think that's an important thing to bear in mind. We also have obvious challenges with supply, with distribution and delivery, with accessibility and awareness, and also just with data and record keeping around, who's getting the vaccines and where they're being delivered. So that's just to bear in mind that I think sometimes we overemphasize, I guess, the personal responsibility or complacency or that kind of thing, when really there's a whole range of factors that lead to maybe under-vaccination. And even when we have the vaccine, we know that that doesn't necessarily equal high uptake in a community. We are trying to achieve quite high coverage with the COVID vaccines. We know that the herd immunity target, or if you will, is pretty changeable and is pretty challenging. So as many people as we can have vaccinated is really what we're targeting here. But we know that people have concerns, and those concerns tend to be focused on the safety of the vaccines. That's really the primary overarching concern that we hear about. The speed of development, people are worried that they've been developed too quickly. In maybe not at this particular moment, but prior to sort of this week, in the last couple of weeks, there's been a very low perceived risk of COVID in Australia due to our great success at managing it and keeping it out of the country in the last year. Some people are quite concerned about the newness of the technology with the mRNA vaccines. And then there's also just groups within the population who don't necessarily trust government or the medical establishment or scientists in general. And there's been conspiracy theories spreading throughout the pandemic and certainly focusing on the vaccines as well. So there are a whole range of issues that we do need to address to make sure that we build confidence for these vaccines. So the COVID vaccine preparedness study really came out of a desire to get on the front foot, I guess, with understanding the needs, the communication needs, the concerns, the decision-making factors that would be affecting people who would be prioritized in phases 1A and 1B of the vaccine rollout. So this study was supported by the Victorian government. As I said, it included a collaboration of researchers from all the institutes at the bottom that you see there, and it was led by our group at MCRI. And we really targeted healthcare workers, so the frontline healthcare workers, as well as other healthcare workers in 1B, as well as what we call the prioritized public. So that's people over 70 and people aged 18 to 69 with chronic health conditions. And as I said, the goal was really to understand the intentions and concerns and information needs, and also to develop guidance for communication strategies that we could feed back to the Victorian government to support and promote the vaccine rollout moving forward. In terms of timing, the study was sort of got underway in mid-January of this year, and we began data collection on February 12th. And we completed the report in the beginning of May of this year. So that's kind of the timeline. And you can see, of course, where key events in the vaccine rollout fell according to that timeline. And there were three main phases of data collection that we undertook. So we had an online survey, which went out to healthcare workers and to the prioritized public, slightly different versions of the survey. And we recruited through professional organizations, networks. The government supported some of the recruitment efforts of healthcare workers as well. With the public, we recruited through 4 primary care practices in Victoria, 2 regional and 2 metro, where we sent out text messages to everyone who might be eligible to complete the survey. We also did Facebook advertising. So it's very much a wide net that we were trying to cast so that we could collect as much data as possible, as quickly as possible, given the pressure of the rollout. So ultimately, we had over 5,000 participants in that survey, which is great. We took, of those participants, we did qualitative interviews with a subset of them, a sample of them, targeting primarily those who had concerns and questions so that we could really explore those in more detail. And as you can see, we did 39 interviews. And then from those, we also did 2 focus groups. And the focus groups were kind of an abbreviated co-design, if you will, where we wanted to target in particular the communication needs and the communication strategies that people wanted to see in action to support their concerns or to address their concerns. So as you can see, we were collecting data for the survey over the course of sort of mostly phase 1A. So most people were looking ahead to being vaccinated. Most people had not yet been vaccinated in the cohort that we were collecting data from. And with the interviews, we really were collecting most of our data prior to the TTS cases and prior to that first ATAGI recommendation in early April. Although, early April. Although the focus groups happened after that. So we did get to explore in a little bit of detail people's thoughts and perceptions around risk presentation with risks and benefits of the vaccines. So in terms of the demographics of our study cohort, the healthcare workers, of which there were about 3,200, were primarily female, primarily nurses, and the majority worked in hospital settings. Among the public, we happened to get very lucky with pretty much a 50-50 split between those who were over 70 and those who were under 70 with a chronic condition. Again, majority female, and we had about 36% from a culturally, linguistically diverse background. We do recognize that one of the limitations of this survey method was that we were targeting people who could speak and read English and who could find these survey links mostly advertised online or distributed through online networks. The overall intention to vaccinate in the healthcare worker cohort was really high at this point. So we saw, on average, 78% intended to get the vaccine. The highest intention was among medical doctors. So 94% of the medical doctors that we surveyed planned to get the vaccine, and those working in the community or private practice setting. The lowest intention was among personal support workers at 58%, but bearing in mind that that was also not a huge sample size. That number was only about 69 participants, and also those working in aged and disability care. So that's really been borne out by, I guess, what we've seen in the rollout since this point, that the uptake in this cohort is lower. In general, across the healthcare worker participants, people were more likely to plan to vaccinate if they were older, so over 50, male, employed full-time, and living in metropolitan areas. And that aligns with what has come out of a lot of other similar types of studies in different states and different settings. Among the prioritized public, we had really high intention to vaccinate. So it was 87% over the both groups and 90% among the people over 70. And this probably reflects the fact that these cohorts, of course, have perceived higher risk from COVID. And in general, those more likely to vaccinate were male and metropolitan, as with the healthcare worker group, and less likely to vaccinate were people from a culturally and linguistically diverse background, and people for whom their highest educational attainment was a trade certificate or diploma. In general, the most frequently cited concerns were the same across the healthcare workers and the prioritized public, and that was safety, long-term effects, and serious reactions. And the factors that we looked at, so we looked at what factors were influencing people's decision-making, and we asked them to identify them themselves, and people most frequently reported among the healthcare workers that the reported efficacy of the vaccine from clinical trials and the reported safety of the vaccine from clinical trials were the most important factors influencing their decision. But when we actually did our analysis, we found that the factors most strongly associated with intention to vaccinate were actually if the vaccine was recommended by their professional society, and if the vaccine was available at their workplace. Also, if the vaccine was required to travel overseas. So this just highlights that these are some areas where we can potentially target to improve vaccine uptake that aren't necessarily something that people were identifying themselves as key factors. Among the prioritized public, they also highlighted the efficacy and the safety from clinical trials as most important to them, and those were important to them in terms of they were associated with uptake in our analysis. But again, also the requirement to travel overseas. So I think that as we move further into the vaccine rollout and we're targeting different groups, it's certainly important to look at some of these levers of driving uptake, as well as sort of the informational and addressing concerns factors. I think we can also look at some of these levers like requirements to travel overseas or making it really available and accessible at a workplace. We asked people in both groups about some of their beliefs about the COVID vaccines. So whether they believed the vaccines were safe, whether they would be important for their health, whether they would help protect others, whether they would cause them to have a serious reaction. And all of these things were strongly associated with the intention to vaccinate. And among the prioritized public, we asked a couple extra questions around freedoms and social norms. And again, we found that these were strongly associated with the intention to vaccinate, which aligns with what we know from other vaccines as well. So social norms is highly influential. We also asked people whether they felt they had enough information about different topics. So we didn't specifically ask about knowledge or test knowledge, but we wanted to know how informed people felt. And you can see here that in general, people felt somewhat lacking in information. And really, we found that only 27% of the participants from both groups said that they had enough information about all of these 5 topics. So how well the vaccines work, how they work, how safe they are. Vaccine side effects was the topic that people felt the least well informed about. And then also the vaccine recommendations, which is sort of how many doses, how far apart do they need to be delivered. And interestingly, of those who did say they felt sufficiently informed, they were 7 times more likely to vaccinate. So that just really highlights, while information can't necessarily solve all problems, information doesn't necessarily drive behavior. We know that just providing information isn't enough to necessarily bring people across the line to drive uptake. However, when people feel sufficiently informed, they are more likely to vaccinate. And so it really highlights that we continue to need to focus on each of these areas and making sure that the information is not only available, but it's also targeted, it's accessible, and it's being delivered in a way that is accessible for people with different levels of health literacy. We asked both groups how convenient they thought that getting the vaccine would be, bearing in mind, again, as I said, that we hadn't really started rolling it out to a lot of the phase 1B groups at this point. So this was sort of a thought experiment, I guess, in a lot of cases. And most of the healthcare workers thought it would actually be inconvenient to get the vaccine, which is a real problem. And they thought that the most challenging thing would be organizing an appointment time that suited them, or waiting a long time at the vaccine location. And it'd be interesting, I don't have data on how people have felt about the process to this point, but I know that anecdotally, there are still challenges with taking time off of work to get vaccines, getting to the clinics. So there are still challenges around convenience. Most of the healthcare workers preferred to get the vaccine at a hospital, with 43% preferring to get it at general practice. This really reflected the setting in which the healthcare workers worked. So it was really more about saying that they wanted to get it mostly where they worked. The prioritized public also thought that getting the vaccine would be somewhat inconvenient. And interestingly, the younger group with the chronic conditions thought that the most difficult factor would be knowing which vaccine priority group they were in. And I think that this really reflects that sort of inconsistent or unclear messaging around which chronic diseases counted for prioritization, what, how they were supposed to determine that, who was supposed to give them that information or confirm that they were able to access the vaccine. Whereas in the older group, the over 70s, the most pressing concern in terms of convenience was really around knowing where to go to get the vaccine. In this group, in the prioritized public, the majority of participants wanted to get the vaccine through general practice. We sort of took a step further from just asking about the vaccines themselves, and we wanted to know more about how people wanted to be communicated with, who they trusted, and what sources of information they were looking for and they wanted to look for, so that we could plan or help the government plan for future communication strategies. And so most people from both groups said that they preferred to get information about the COVID vaccines from government websites and sources, and through discussions with their personal healthcare providers. In terms of trusted spokespeople, so people that they wanted to maybe see in communication campaign ads, that kind of thing, medical professionals, scientists, and researchers rated very highly. Their personal healthcare provider was also, highly trusted. Representatives from the government and politicians were sort of uniformly not highly trusted in this particular context. So as I said, we had 3 phases of data collection. And so we had all that data came from the surveys. And then we also did these qualitative interviews. So 39 qualitative interviews, 19 with members of the public and 20 with healthcare workers, I believe. And we also conducted, as I said, 2 focus groups, and the focus groups were mixed participants. So it was a mix of sort of 2 healthcare workers, 4 prioritized public, and vice versa in the 2 different focus groups. And really, this section, I'm not going to go into a huge amount of detail, and I'm going to kind of condense some of our findings from both of these forms of data collection. But both targeted, we oversampled, I suppose, from people who in the survey said that they were not sure about getting the vaccine, or that they weren't going to get the vaccine, or if they were healthcare workers, people who said that they were not sure if they would recommend the vaccine. So we really wanted to explore in a little bit more detail the reasons driving that, and also what might address those concerns or address those issues. So we used this WHO model to organize our interview findings, and it was the Behavioral and Social Drivers of Immunization model, the BESD model. And it's sort of a hybrid based on a few different behavior change theories. And we really looked at the motivation. So as I said, we sampled people specifically along sort of the spectrum of motivation. And we found that there were definitely people who never planned to get the vaccine, who were firmly opposed to it. But there were also quite a large group of people in our sample who were just waiting. They weren't necessarily not going to get the vaccine, but they just weren't making any action now. And then there were people who did plan to get it, but they were still quite confused or uncertain around a lot of the practical issues around getting it. So those things about knowing where to go, getting information about who was eligible, that kind of thing. We explored a little bit more how people were thinking about the vaccine, so the risks and benefits, and also those social processes. So who was influencing their decision-making, and what information and misinformation were they being exposed to. And we explored the risks and benefits in particular in the focus groups. So the perceived safety, one of the key findings I think here was that people were not only concerned about serious reactions or long-term side effects, they also really wanted more information about expected short-term side effects. We did talk a bit, as I said, about blood clots and TTS, but given the time frame of our data collection, it wasn't a huge focus, and it wasn't necessarily the main driving concern among people who had questions about the vaccines. We asked people around how they wanted to see risks presented and compared. And this is something that I know we've all been challenged with for the last several months. You know, what is the best way to present difficult concepts, changing data around risks and benefits? So we had people brainstorming with these sort of live whiteboards during the focus groups. And the problem was that it was sort of a mixed finding. Some people really wanted the everyday comparison to, you know, falling down the stairs, that kind of thing, because it at least made it understandable and real, while other people felt that that was a really facile comparison, and they just wanted to see it compared to risks of other medicines or risks of getting the disease itself, of COVID itself. So there certainly is a need for, I think, a range of different ways to present risk. And then when we ask people about the benefits, the potential benefits of vaccination, the really common theme here was freedom. So it was freedom from lockdowns, financial freedom, freedom from school closures, and then as well as that, it was also, you know, individual protection, community protection, and social and economic benefits. So I guess we know that COVID beliefs are changing all the time. Every news story changes some people's beliefs. Every, you know, the more people know who have been vaccinated, the more normalized vaccination seems, that can change people's beliefs. And what this really highlights is the importance of communication and of every conversation. So conversations with friends and family, as well as conversations with healthcare providers. Every conversation makes a really big difference in a way that we don't necessarily see in discussions about childhood vaccines or maternal vaccines or things where people's views are a little bit more established and static. So our recommendations and the sort of next steps that came out of our research study, and also some of the other work and findings of other groups that have been going on around the country, focused a lot on the communication needs and the communication strategies. So in terms of the content of communication, it's really key that we are communicating regularly about vaccine safety and effectiveness. You know, we know that these are the primary concerns that people continue to raise, and the data does change regularly. And so that's a real challenge in this space. The expected side effects, as I said, people wanted to know about the expected side effects. They want to know how long they might be out of work. And if they are going to have to stay home from work, they really want to know whether there's any sort of supports for them in that space. They want to know, or we recommend that people communicate about the benefits of the vaccines, particularly when we have really low community transmission of COVID. Presenting the vaccines as a way out of, not going to ICU or not getting sick from COVID doesn't really resonate as strongly as presenting the vaccine benefits that have less to do with disease prevention and more to do with, freedom and reopening. But of course, we do still really need to focus on the severity of COVID to remind people that we're never going to be completely free of this disease, and it will be back in the country. It is back in the country now. And that really is the driving reason that we're doing this, rolling out this vaccine. And we also obviously need to communicate about vaccine availability, where to go, who can get it, and how to make that appointment. So we recommend that there's a real diverse campaign where we use humor, where we use pathos, where it's, engaging. Everyone's, I think, shared these various campaigns from Singapore and New Zealand and the UK, but I really think that kind of strategy is critical, even if we don't have supply for everyone, because I think the lack of communication in this about the vaccines allows people to sort of harden into their particular concerns without having those addressed. With communication delivery, it's really a key finding from our research was that people wanted to get personalized information about the risks and benefits of the vaccines. So they wanted to understand how the vaccines would affect them if they had diabetes or if they were a particular age or from a particular background. So the more personalized information we can provide, the better. And also people wanted to hear from real people. So not just medical, professionals and scientists, but also in the style of like a campaign ad, they wanted to hear from people who were like them and who were more diverse. Of course, as with any public health messaging, it really needs to be clear and simple. If it's shareable and engaging, that's even better because it means people will engage with it multiple times and that message will have greater reach. And we also need resources to support healthcare workers. So healthcare workers are the most trusted source of information about vaccines, and we know that, and it's such an important relationship, and a recommendation from a healthcare provider to get the vaccine is a huge driver of uptake. So we need to be able to provide resources to support them to have those conversations. So things like decision aid tools and information about those risks and benefits for different groups, but also, I was really happy to see recently the Medicare reimbursement number for consultations, because those consultations are lengthy and complicated. And then we also just need to make sure that we're constantly building trust through transparency. And I think that's a real challenge, but people know that information will be changing. They don't want to be over reassured, but they don't want to feel like things are being hidden from them either. I mentioned requiring the vaccine to travel overseas. There are some requirements that may be useful, but a key finding was also that we need to be careful when we're taking steps towards requiring vaccines or mandating vaccines. It's really important to make sure the vaccines are available, that questions have been answered, and that we are not jumping straight to sort of a punishment strategy with vaccine requirements. And of course, we need to overcome access issues and supply issues. So looking ahead, what are some of the silver linings or the opportunities, I guess, that come from this COVID vaccine unprecedented rollout? I think one thing is better record keeping for adult vaccination. I know there's legislation coming through this year to require more vaccines, the NIP vaccines, to be recorded on the air. I think the air is an amazing tool, or could be an amazing tool for research and for public health promotion. But certainly we need better and more consistent record keeping of adult vaccinations on that, particularly if we can add in elements like pregnancy status or at-risk status or migrant status. If there's any way to link other sort of categories into that, I think that would be very helpful. Quite a good article in the MJA about that. Also, just the general focus on adult vaccination programs, and motivating factors for adults. I know that quite a lot of the focus, at least for my research, has been on childhood vaccines or on pregnancy vaccines, but I think that the COVID vaccination program has put all of everyone's attention on adult vaccines, and I think it would be a shame to squander that. And certainly we should try and pivot to, promoting other adult vaccines with some of these strategies. We've also seen a huge investment in community engagement, so from a government level and then from within community organizations, in sort of training people to become vaccine champions. And that inreach into different communities is critical and should absolutely be sustained to support other vaccine programs and other health promotion efforts. I'm sure that we have seen higher vaccine-related health literacy in the population in general. I don't know whether that'll be borne out as increased uptake of other vaccines, but it certainly helps when you are now communicating about immunity or about vaccine effectiveness. People are a little bit more aware of what that means. And then there's just ongoing opportunities for social science research and a focus on communication and vaccine, the drivers of vaccine acceptance and uptake. So just to quickly highlight a couple other studies. So as I said, our study was focused in Victoria, the vaccine preparedness study. In New South Wales, they're doing a study on vaccine messaging. So they're doing similar qualitative research and then looking at testing specific messages for communicating about the vaccines. And in WA with CoronaVax, They're also doing mixed methods research, looking at community interviews and social media analysis. So all of these studies are sort of working in collaboration with one another, and hopefully the findings from each state will be able to sort of cross-pollinate into other settings as well, particularly as we have sort of different COVID risks and different vaccine rollout challenges at different times. So I just wanted to thank, we had a really great study team. The vaccine preparedness study was done in an enormously compressed time frame, and I thank everyone who was involved from all of the different collaborating institutions, the Victorian government, as I said, and also our project advisory group. So thank you very much, and I will hand over back to you, Robert.
Yeah, that was just absolutely brilliant. And there's a lot of questions, but we will save them to the end. I've got, as a co-chair, Professor Margie Danshan from the MCRI as well, and so she'll help me to make sure all the appropriate people get asked questions. So without further ado, I want to introduce Professor Paul Griffin. Paul is an infectious diseases physician and a microbiologist. We've seen him a lot giving great communication to the general public. He has a research interest in malaria and preventing its transmission, so not the same kind of bug, but same kind of questions. It's really good to have Paul with us today. And the other thing for people who are wondering why are we out of order, Dominic Dwyer was held up with urgent government priorities, but I believe he'll be available between 9:20 and 9:45. So it's Paul first, and then Dominic in 20 to 30 minutes. Oh, go ahead, Paul.
Thanks very much, Rob, and thanks to the organisers for putting such a great meeting together. It's obviously difficult times for a lot of people in this group at the moment, and great to see such a topical meeting come together on at a time like this. And thanks very much for the invitation to speak. I have a few relevant conflicts of interest, but none of those have significantly impacted the content of my talk. What I'm going to talk on today, so the title, of course, is Innovations in Vaccine Design. And, it's a pretty expansive topic at the moment. I'm going to touch on some of the innovations underpinning some of the current vaccines in use, talk about some new vaccines in use and why perhaps they're being developed, and also look at some novel delivery methods. So a bit of a whirlwind tour. Obviously can't cover every new vaccine coming through, given I've got about 20 or 25 minutes. So, of course, a lot of people in this group will be aware that coronaviruses, whilst very topical at the moment, have been around for some time. And this isn't the first coronavirus that's caused problems for humans. We've, of course, had the first SARS back in 2003. And the next one that was a problem was perhaps MERS in 2012. But obviously the magnitude of this one is far greater. And if you look at the death toll in the little cartoon on the right, depicting pandemics over history, the current SARS-CoV-2 currently sits at 8 and hopefully won't keep progressing through that little cartoon there. So coronavirus vaccines, a lot of people were saying we've never had one before, which I guess fueled a little bit of skepticism about our ability to make one this time. But we did actually have quite a few for animals in the past. And the reason I think it's important to note that we've had previous significant coronaviruses in humans is that we did have quite a bit of vaccine development that really kicked off some 20 years ago with the first SARS. We did have some issues there that fortunately we haven't seen with the current group of coronavirus vaccines, but we had lots of really promising candidates that had some really good results, particularly in animal studies. But of course, they couldn't be developed further through clinical trials because there weren't any cases that virus was eradicated with infection control measures, because it was quite different in terms of the severity of the disease and how it was transmitted. But I guess what that really underpins is that we didn't start trying to make vaccines for this in December 2019. We had some really good platform technology that was already underway. And if we look at the current tracker, there's some 94 vaccines that have entered clinical trials. Obviously, these numbers add up to more than that because some that are still completing phase 1 trials have been all the way through to being approved or unfortunately abandoned. If we look at the mechanisms that are being used for COVID, basically it's all of them. I think that the one that's talked about the most, of course, is mRNA. which again, most people here will be familiar with this mechanism. But what we do here, our goal, of course, is to present something to the immune system against which we'll get a response that when we're exposed to the pathogen, that the virus in this case, will mean our immune system is primed or prepared to respond to that. So mRNA is the instruction to make protein, and the protein we're desiring here is the spike protein. A few significant issues here. Given mRNA is inherently unstable, it has predominantly been coated in some kind of oil or lipid layer, which has presented a bit of allergy risk and underpins the risk of anaphylaxis that we do see with these vaccines, and does also have some inherent issues in terms of storage and transport and that extreme cold chain, although our stability data, we can keep these vaccines outside of that. Fortunately, here it's a really clever mechanism because the mRNA itself helps to boost the immune response. So while we do need multiple doses for the majority of lead candidates, we haven't needed to add adjuvants or anything like that. And they have, of course, proved safe and very effective. But an emerging issue seems to be myocarditis. So we'll have to watch this space with that one. There are quite a few candidates here. So obviously Pfizer and Moderna. Quite a few other mRNA vaccines, and Sanofi, for example, are going to be doing some of their studies in Australia fairly soon. And there are quite a few DNA vaccines that are also coming through, similar in principle, I guess, but the majority of these are going to be delivered by novel delivery methods, and I'll touch on some of these candidates at the end. So Pfizer, I'm just having some technical issues here with my equipment, so if I drop out, please let me know. So BioNTech has actually been around for some time, and they were predominantly focused on other areas before obviously making the switch to COVID-19, and then partnered with Pfizer for some of their clinical trial logistics and manufacturing, and had some other partnerships in other countries. And if we look at the evidence for that vaccine, and not to dwell on this too much, most people are aware it was some excellent efficacy. And if you look at that graph, red is people that received the vaccine, which is a pretty flat line there, and blue are people that received placebo that continue to develop cases, so the cumulative incidence there. So again, a fantastic vaccine that we're obviously relying on quite heavily. Moderna is a company that didn't just start obviously with their COVID candidate. They've been around for quite a while, and actually have been in the business of making vaccines for some time, as well as therapeutics and things to prevent cancer. And if we look at their pipeline, you can see they've actually got quite a lot of experience, although haven't progressed any candidates quite as far as their COVID candidate. And I was actually involved in some of their work with an RSV vaccine. Again, while it's obviously proven extraordinarily effective with COVID, their technology had actually been around for some time. So they started work on their COVID candidate in January last year, first vaccine into human trials in March, and published their results in February, large study that once again showed some extraordinary efficacy here with placebo, the cumulative incidence continuing to rise, but those that received the vaccine having a very low incidence. So again, an innovative technology that's proven extremely successful for this pathogen. If we look at the next candidate, so viral vector, so in this case, instead of directly injecting those instructions, we deliver them via a vector. So in this case, a benign unrelated virus. With a lot of the others, it's a benign human adenovirus, and similar in principle that once inside, the viral vector also helps the generation of an immune response. So once again, we don't need an adjuvant with these, and typically we do get quite good cellular and humoral responses, but have proven a little bit reactogenic and can have some issues with immunity, either pre-existing or newly generated against the vector. Not necessarily new technology, it's been around since the 70s, but did have some issues early on. And adenovirus 5 vectored vaccine for HIV didn't really work that well, but some promising candidates for Ebola have just recently been licensed. So again, while it might seem innovative in how it's been applied to COVID, it's actually been around for quite some time. And I think people are aware of the candidates here that utilize this technology. Oxford-AstraZeneca particularly, which despite a lot of chat about the issues, is a very safe and effective vaccine. Sputnik 5 and the J&J vaccine, I guess the other candidates people have heard a lot there that have come through. In terms of AstraZeneca, I won't dwell on the evidence, but again, I think most people here probably know that overall it is a safe and effective vaccine, but lots of different papers with lots of different results. But again, a vaccine that has sort of proven effective in this case. I'll move on to protein now. So a much simpler technique, I guess. The target antigen here is just simply produced in the laboratory. But in doing so, while it might sound like it's an easier way forward, we do then need to do some things to it to I guess, address some of the shortcomings there. So we often need to make it into something that more close to us, and that gets called things like nanoparticles or virus-like particles. The molecular clamp was one way here as well. And often we need to combine this with an adjuvant to make sure we get a strong enough immune response. And while this as a group is potentially a little bit behind the first two that I talked about, of course, Novavax is progressing well through clinical trials. And there are lots of other candidates that are coming through that rely on this technology, including Clover, which again is about to bring some clinical trials to Australia. Novavax, again, while people are hearing about their vaccine at the moment, and it does appear to be very innovative technology, they've been around for quite some time, have a very good track record of making vaccines for lots of other pathogens in the past, yet to get anything all the way to commercialization. But if we have a quick look at the pipeline, again, lots of exciting candidates for a lot of other pathogens as well. And again, lots of really good evidence that's come through here. Was the first vaccine to commence human trials in the Southern Hemisphere over a year ago now. And they've recently had some press releases showing some great efficacy from their larger phase 3 studies. Finally, in terms of other platforms, inactivated or attenuated, again, a little bit more traditional. Here we simply take the pathogen, in this case the virus, and in some way inactivate it. Most commonly with these, inactivation with a bit of propionyl-lactone, which binds to the genetic material and makes it unable to replicate. This is scalable and typically inexpensive and been used, but I guess as a group, we haven't seen the same efficacy that we've been very fortunate to see with the other platforms. Here are some of those, and some others. And there is an interesting one which is a bit more sophisticated, which is also in clinical trials there at the bottom. And so I just thought I'd touch on some more vaccines that people may not quite have heard about. And one question I often get asked when we talk about new vaccines coming through is, why do we need to bother? What's the business case for continuing to develop and progress through clinical trials, new vaccines? And again, none of this should diminish our confidence in the currently available vaccines. But what's clear is that, we don't yet have a perfect vaccine, and we perhaps never will. It would be great to have a vaccine that had perhaps lifelong immunity, was maybe a single dose, had no or few side effects, was potentially room temperature stable, easy to make, very stable, and less susceptible to changes from emerging variants. So, a pan-coronavirus vaccine, if you will. So there are a few things that we're still chasing on that wish list, which is why there are a lot of other vaccines coming through. Most people have heard of the University of Queensland vaccine, some very clever technology there. What we know about some of those protein vaccines is they can fold or change shape away from what we're hoping to get an immune response to. And in this case, a molecular clamp was applied to keep it in the right shape, which does seem effective, at least in phase 1 clinical trials. But unfortunately, the initial clamp chosen did cause some issues with HIV testing. So that has been abandoned. But given how well this performed in the early phase clinical trials and in animal studies, I'd be very confident that very clever group will be able to do something with that technology into the future. I'm actually also doing a study with the Serum Institute of India, where their vaccine, instead of being targeting the whole spike protein, is more specifically targeting the receptor binding domain. With the theory here, they make that a little bit less susceptible to change from new. So this is a vaccine that's underway in clinical trials. And I'd like to talk about this candidate that's also in early phase clinical trials, because it is the first oral vaccine. And here it's essentially a vector sort of vaccine, but instead of using a benign virus, a harmless bacteria, a probiotic essentially, is used as a delivery mechanism. And this is one that's taken orally and is stable for long periods at room temperature. So again, if this one proves safe and effective in clinical trials, some of those properties will be very useful in terms of a vaccine to be used in. And another study that's kicking off here very soon is with this company, which is again an adenoviral vectored vaccine. But the innovation here, I guess, is most of our adenoviral vector vaccines so far are not able to replicate or reproduce. But this one is able to undergo one cycle of replication with the theory here that will boost the production of the spike protein some 100-fold. And this, if proven successful and safe in clinical trial vaccine, that could be delivered intranasally, which would obviously be very helpful. And I'll come back to that in a moment. So, of course, we've got a lot of intramuscular vaccines that are going well, but it would be nice to have some vaccines that could be given by alternate delivery methods. So I'll just quickly touch on some of those. In terms of giving something via the skin, and we're going to have a specific talk on this later, so I look forward to hearing about that. So I won't cover this too much, but there are particularly some DNA vaccines that have a number of different ways of being introduced into the skin, including with a tiny jet or an electric pulse, for example. And so obviously this is some very promising technology that we're eagerly watching. The nasal vaccines, of course, great in terms of avoiding a needle and syringe, but the premise here is also that given we're administering the vaccine via the mucosal route, that hopefully we'll get an increased mucosal response that might go a little bit further in terms of actually blocking the ability to get infected. So essentially a transmission blocking vaccine, hopefully. But one challenge we usually do face there is it's very hard to get a potent enough response to do that. So that's why these vaccines are often combined with some kind of other innovation to boost that response, as we heard about with the TetherX one. But there are quite a few others, essentially in phase 2. And phase 1 that are looking promising, but I guess we need some more time here to get those developed. And of course, oral. So a very challenging route to develop a sufficient immune response to get good enough protection, but there are lots of these underway. There's Vaxart, which is based in the US, which have a history of specializing in oral vaccines, use the same vector as CanSino and Sputnik 5. Their phase 1 data did show some promising. Phase 2 is underway. Same vector virus used with Immunity Bio, and their innovation here, I guess, is that they not only, but they've added in the nuclear capsid. They have some non-human primate studies and some other animal studies that show some promising results. And so they've moved to phase 1 trials, looking at a range of different delivery methods. And it might be that intramuscular followed by oral or sublingual or intranasal boosting might be the way to go there. And they've demonstrated some really comprehensive immune responses, including some mucosal antibody responses, which again may go a long way to helping with some transmission. And Symvivo, as I said earlier, spike protein by harmless bacteria, which can be given orally. And again, we're eagerly awaiting some results there. So I know I whipped through that very quickly. We have a number of great and effective vaccines that have been developed in record time, but largely driven by a long background of innovation over a period of time, perhaps 20 for a lot of those. So we haven't compromised any of the usual steps that we like to do in clinical trials to prove they're safe and effective. And of course, we've seen some exceptional results in the large clinical trials that have now been real world experience. And we do have many new candidates under investigation. Not that our current candidates aren't exceptional, but there are some properties I guess we would still like to see with new vaccines, and hopefully some of those will provide those for us. And I will stop there.
Paul, I sold you short. What a brilliant talk, just superb. Let's deal with some burning questions. One of them was, what's the one thing you'd like to convey to the public to build their trust? Jessica?
I saw this question. This is, it's hard to make one recommendation, but I guess I would say the key thing to really highlight. So the question also said, I said information wasn't enough, basically. And so what would I do instead? And I think the key is to highlight and reinforce motivation. And so by that, I guess, I mean, you're not going to be able to answer everyone's questions. If you're thinking about sort of a broad campaign, it's not really about telling everyone everything about how the vaccines were developed, how safe they are, how well they work, how to get them. That is really critical. And that's definitely something that needs to be communicated very clearly in sort of the public health messaging. But if you wanted to design a single overarching campaign, I think you could do a lot worse than highlighting motivational features like sort of the New Zealand ad, if you've seen that, which highlights kids being able to stay in school, people being able to make plans for the future, planning a wedding, planning travel, going overseas, returning to, international students returning, all of those elements that I think are more the emotional heart, I guess, of driving vaccine uptake. But I guess the other thing I would say is that one message and one campaign is not going to solve individual people and individual groups' concerns and vaccine hesitancy. But I would love to see something out there like that.
Paul, what do you want to summarise? I know you just summarised, but what do you feel is the key message? I really undersold you. You've done an amazing body of work. Well done. And what do you really want people to take away today from your talk?
I guess just how great it's been that we have been able to develop such good vaccines for this virus. And, people are debating efficacy results and reductions with variants and things like that. But I think if you'd asked a lot of us, 12, 14 months ago, what sort of efficacy we'd hope to get from some of these vaccines, people wouldn't have believed when you said the results that we've seen would be what we could expect. And, I guess now we're a bit complacent when, people are complaining something might only be in the 80s in terms of efficacy. Whereas, again, had we thought at the outset that would be what we would be able to get, I think a lot of us wouldn't have believed that. So, just to be aware of, how much great work has gone into these vaccines, how effective they are, and how, much of an important tool they really will be for us to, move forward with all of this.
Well, it all comes from building on the shoulders of giants, and it's great to have so many giants here today. I'm going to switch over to Dominic now because he's online, and we'll look forward to hearing his insights. Thanks, Dominic.
Great, thank you very much. And I do apologise for mucking everybody around this morning in terms of timing, but we're clearly having to muck around with a crisis in COVID-19 activity in New South Wales. So look, I've been asked to just give an update on COVID-19, and clearly you will have covered some of the things already. And look, I thought it's difficult, obviously, to do all of this in 20 minutes or so, but I thought that I would just outline some of the issues that New South Wales Health Pathology, which is the organisation I work for, has had to face in the context of COVID activity, really in the last 12 to 15 months or more. And I'll cover a number of areas that have proved sort of problematic, I think, in a number of jurisdictions. But I guess what I'm talking about today is really a kind of more statewide approach to public laboratory testing, and I'll explore that a bit with you. So, look, clearly we're up to the stage, as everybody knows, this is last week, of course, but of hundreds of millions of cases now worldwide, and almost 4 million deaths from SARS-CoV-2 infection, knowing, of course, that this is a gross underestimate of the number of cases. Even within Australia, where we have good testing, serologic surveys that we've done would show that there's at least a 4 or 5-fold number of cases confirmed serologically than are picked up with PCR and the like. So this is, I just put this up because this is actually the structure of New South Wales Health Pathology, set up about 7 or 8 years ago to coordinate public laboratory testing in New South Wales. And I like this picture because it really, the organisational chart really does look like a virus. But anyway, my role is as Director of Public Health, as well as running the ICPMR here at Westmead. And that's a new position that was really designed to coordinate at least the laboratory aspects of testing for diseases of public health importance. So in our approach then, when COVID-19 started last year, was to use this new statewide service to undertake a centralised approach to testing strategies and rolling out testing to try and get away from the problems we envisaged of individual labs trying to sort out what they needed to do and struggle with reagent issues and sending around of samples for testing and so on. And also I'll cover just some of the newer issues that have arisen in terms of things like saliva testing for our quarantine workers and other occupational sort of targets, as well as just quickly going over the issues with rapid antigen and antibody testing that have had certainly a lot of media play. So look, if you look at the way we approached testing in New South Wales, obviously got PCR, then serology, virus isolation is undertaken at Westmead to provide both material for testing and quality control and so on, but also for research purposes. And then, of course, whole genome sequencing to aid public health responses. So we undertook a staged-wide approach to managing the demand for PCR, because as everybody knows, in sort of January and February last year, things really ramped up. So we started off with laboratory testing initially in the ICPMR on the 22nd of January, with the first case diagnosed, I think, 3-4 days later and confirmed down at Vidral. Then other laboratories opened up in a staged approach over the following 4 or 5 months. And that included initially the other big urban laboratories servicing the big teaching hospitals, then some of the more regional laboratories, and then moving out into smaller metropolitan laboratories, but also rolling out testing initially with the Gene Expert, but with other platforms later on, to rural and regional laboratories, which previously had not done much molecular diagnostics in the past. And so those phases have gone on over 6 months or so. And then I'll also talk a little bit about a place called EMAI, or Elizabeth MacArthur Agricultural Institute. So the EMAI is a public health veterinary laboratory at Menangle, which is in southwestern Sydney, on the fringes of the city. And they have very much worked up the ability to do large-scale testing because of their experience with the equine influenza outbreak a decade or so ago. They were performing up to 30,000 PCR tests for equine flu at that time. So we asked them very quickly to get on board with helping us with testing, because we could already see our hospital laboratory starting to sink under the demands of testing. We arranged for them rapidly to be accredited with NATA to undertake human testing, and provided microbiologist supervision from Westmead Hospital. And they provided surge capacity initially for a number of the urban labs, Westmead, Nepean, Liverpool, and also, as time has gone on, some of the other laboratories as well. We also did very, very briefly undertake some work for some Victorian laboratories that were in the midst of their major squeeze with their second big outbreak. The other thing we also did was that they had experience with viral transport media production. So we were under great pressure because the market was tight in terms of viral transport media and swabs. And in fact, a number of what we found to be poor quality viral transport media were sort of flooding onto the market. So we validated and accredited the viral transport media that they were using for equine influenza and turned that across into human testing. Of course, we didn't use the same swabs that they used to stick up a horse's nose, because there's something else. And they've also been assisting us with saliva testing for occupational screening of our quarantine workers. And so it was really extraordinary to get them ready to go within a week of all of our requests. And they've done well, well, these figures are old now, well over 50,000 diagnostic PCRs and 150,000 saliva tests for us, and are very much part of our testing strategy in New South Wales. We also had already in place a GeneXpert rapid PCR system for influenza and RSV over the last 3 or 4 years now in New South Wales, rolled out to over almost 40 labs in New South Wales, including rural and regional labs that otherwise didn't have molecular testing, to provide a rapid service for flu and RSV. But when that company then started producing cartridges for SARS-CoV-2, we use the same system to roll those out. That system is centrally managed, integrated with the laboratory information system, and there's a centralised QC mechanism for this. So this has really been very successful in providing rapid testing, and we can do things like move machines around, like we've just moved down last week, testing into the snowfields for holidays, which of course have come to a shuddering halt in the last week. There are alternative rapid NAT systems available, and they're all perfectly good and so on, have been validated. But our experience with the GeneXpert means that it was actually relatively easy to roll out, even though there were certainly supply issues. We were lucky in that, being one of the largest users of GeneXpert, the largest centrally managed rapid PCR platform in the world, apparently, that we had better access perhaps than others to this patchy supply of cartridges. The other issue that we spent a lot of time addressing early in the piece was rapid antigen testing. And look, I think we all know in this audience the pros and cons of that. And that a lot of this has been driven by media interest and politician interest in rapid antigen testing, but without an understanding of the pros and cons of this sort of approach. And obviously the cons are mainly around the sensitivity, and we saw an explosion of these sort of in the US, but the FDA in fact have had to double down on these because of their the poor performance of many of them. Certainly the assays are reasonably sensitive in the first few days of an illness, when viral loads of course are generally high, and yes, they are quick, but their ability in a low prevalence environment, I think, is really problematic, and we continue to say that they're not suitable for use in the Australian environment. Saliva testing for SARS-CoV-2 is sort of ramped up because of the need to screen our quarantine workers in both, well, certainly in Victoria with the issue, well, all states have had issues with leakage from quarantine workers. You know, it's pretty difficult to ask sort of healthcare people to have a daily nose and throat swab, given how uncomfortable they can be. So saliva has been the option. We don't use it for diagnostics, but with a very occasional exception, for example, in children or whatever. But in general, they're reserved for occupational screening, which has a different regulatory and so on environment, which is easy. And there's a debate about what methods you use to collect saliva. I won't go into that sort of detail, but in broad terms, saliva PCR is okay for screening when you're doing it daily in people, because that gets over the problem of reduced sensitivity and lower viral loads. We only do PCR-based assays on saliva. People have looked at doing antigen testing on saliva, but the sensitivity issues there are problematic. And sure, you can do other sorts of tests, not immediately applicable to diagnostics on saliva, but I won't go into those. But we very carefully keep it separate from our clinical testing in the laboratory. The other issue has been the emergence of serology tests, commercial ones and so on. And again, we adopted a phased approach in New South Wales, rolling out immunofluorescence, which had been developed at Westmead, and neutralisation assays. And the advantage of those assays, particularly the IFA, is that you could do IgG, IgM and IgA, which is useful in trying to work out, particularly for some of the people with low positive PCRs, whether these were reflecting older infection or acute infection and so on. And we provide that as a service to the ministry. Testing's been rolled out to other laboratories in the months afterwards, and now commercial assays of one form or another are available in at least the major hospitals in Sydney. Although the performance of those assays, I won't go into detail, is perhaps not as good as some of the, in our experience anyway, with the immunofluorescence assay, but there are pros and cons with all of them. Rapid antibody testing, again, is something that had a lot of airplay, various lateral flow sort of measures, most of them initially coming, I must say, from companies that I'd never heard of. And again, a bit like the rapid antigen assays, there are a flood of these sort of tests hitting the market, but their performance in general has been unsatisfactory, and certainly the Doherty and New South Wales Health Pathology at Westmead have evaluated many of these and published and so on, and basically find them not as useful, clearly, as standard serologic tests, and we don't support their use in the public sector in New South Wales. Genomics, of course, has been a highlight of the response to SARS-CoV-2, and this is just a fish plot of work done at Vitaly Sinchenko's lab at the ICPMR, where this sort of gives you a time scale, an indication of how big individual clusters are, and they're coloured differently, and how long those clusters last for based on rapid genomic sequencing. And it just shows you what happened on the left-hand side in the early parts of the epidemic, where there were lots of different clusters as people were returning from travel overseas and so on. And those clusters are acted on and so on. And then later on the right-hand side, seeing new clusters develop related again either to overseas travel or to importation from other states in New South Wales. So this sort of data is particularly good in understanding how clusters evolve and persist and expand or decrease over time. And also the other thing is the rapidity of this testing. So the lab can get results out sometimes within a day with the nanopore sequencing, although that's less reliable than Illumina sequencing for cluster analysis, but generally has been very much a new addition to our armamentarium in managing disease. Just to sort of get towards the end now, finishing up with variants of concern, of course, because this is a major issue, both clinically and epidemiologically, and also, I must say, in the media. And of course, anemia has gone through various pathways, and we're now very keen on the use of the Greek alphabet to make things easier for people to understand. But you can see on this slide the different assignations or subtypes and so on, depending on the systems you use, where they originated from, various countries and so on, and when they first started to appear. And this clearly is an issue. There's even now a Delta Plus variant, which I know was picked up at Westmead, I think the first one in the country, I'm not sure about that, with further mutations in that Delta strain. So again, this sort of monitoring of variants is really important. This is just data from the centralised recording of VOCs in Australia, just to give you an idea of the proportions of the various subtypes variants appearing in Australia. And of course, we are seeing very much an increase in these Delta variants and Kappa variants that originated from India, and they're now becoming pretty well the dominant one, at least in New South Wales. There are, of course, other variants that are of interest, not yet sort of classified by WHO or other organisations as variants of concern, but as you would expect with an RNA virus, these variants appearing and causing outbreaks and so on, are detected in various countries and circulating at various levels depending on where you are, and monitoring of those for their things like transmissibility and even clinical characteristics is ongoing. Treatments for SARS-CoV-2, look, some of that's been covered, and I noticed Paul was talking about vaccine development and so on. So look, the treatments for COVID-19, if you're going to summarize it in a word, essentially unsatisfactory. Certainly discussion around how to treat severe disease or hospitalized patients, whether they're ventilated or not ventilated, requiring oxygen or not, a range of medications that you know, being used in various clinical trial formats or just generically, essentially problematic in terms of trying to understand what real value they add over and above the supportive care. But there's not time to go into the ins and outs of what's a pretty complicated environment. Of course, you can take, you know, in developing the drug pathways for likely targets, just like we did with HIV. And this is an article from Eric de Klerk in Microbiology Australia, going through that sort of process, which I won't go through, but is a way of looking at targets and potential targets, and indeed getting to the stage even of combination therapies, like again, the approach we've taken in HIV and Hep C and other RNA viruses. Vaccines, look, I think you've heard about those already, just to point out that there's very, very many of them that are either candidate vaccines going through clinical trials and so on, and preclinical trials and then clinical trials. Still, you know, I guess only a modest number currently available in clinic practice, but I think, as Paul was saying in the end of his talk, pretty amazing how quickly these vaccines have been rolled out and what a model this will be for future pandemics. And then just to finish up, again, a lot of discussion about the origins of SARS-CoV-2, and this is just a picture that was taken on the WHO mission to Wuhan to look at origins, just showing the complexity of having marketplaces near vast amounts of accommodation in Wuhan. Not that I'm saying that that's the origin of the virus, but it's just a demonstration in one picture of the complexity of the interaction of humans and animals and so on. And if people want to read about that, I've left, or you can read the report itself if you've got some time, a couple of 100 pages for you, but an interesting report. And of course, that's received an enormous amount of excessive media and political interpretation, way out of keeping with the science, but that's politics, I guess. So look, I'll finish up there and thank you very much for allowing me to talk at late notice. Thank you, Robert.
Well, wonderful, Dominic. Yet another clear and comprehensive talk. I think we all feel privileged to have the speakers we have. The burning question is to build on what you just said, Dom. What are you able to say about our better understanding of the origins? Do we need to know anyway? And if we need to know, how will we apply that knowledge?
Well, look, I think, yes, we do need to know. I think the need to know is now clearly much less about, well, what happened first time round, because it's happened, and we just need to get on and you know, respond as we are. I think the key is, how does this help us next time round? And we've seen with every pandemic or big outbreak, if you look at SARS, the improvement of international notification after SARS in 2003, and for example, the involvement of China in that communication, clearly an improvement. We saw with swine flu in 2009, you know, how things improved in pandemic planning and ascribing severity to our pandemic planning scenarios and so on, those sorts of things. I think, again, we'll see benefit after this pandemic is over about how to do it next time around. I think the difficulty this time around has been that because origin investigations can take decades, I mean, it's taken, you know, over 30 years with Ebola, 15 years with SARS, you know, to nail the kind of origin. This will take time, and because it takes time, and because the science is slow and incremental often, then that leaves a vacuum that allows, dare I say, poor politics, poor media review, poor interventions one way or the other. And the problem with that is that it impairs the collaboration and cooperation you need to do this sort of work. So anyway, it's really complicated. I mean, I think we'll get, figure out the origins. We usually do with most of these things, but it is slow, and it needs openness and transparency from all sides to do the work properly.
Thanks, Dom. Politics seems to dominate in a lot of what we do and how we think. There's a question for Jessica. How can we improve our communication and the politics around culturally and linguistically diverse populations? Obviously, it's not just information that's translated. So what have you been doing? What have you been learning?
Well, with culturally and linguistically diverse populations, as I said, they were not specifically targeted in our research because we were sort of using online methods and working under short time frames. But we have been working with other groups, and we've been doing quite a lot of community training. So Margie Danchin and I have been doing, on behalf of the government, we've been going and delivering training to various community leaders in order to help them answer questions and build confidence in their communities. But I guess the challenges with culturally and linguistically diverse groups are that, of course, there are different languages spoken. People are accessing information often from overseas, which may or may not be accurate or up to date for Australia. But also trust in the government doesn't necessarily, it needs to sort of cross all topic areas, right? So if for whatever reason there is not, adequate immigration support or financial support or something like that for culturally and linguistically diverse groups, they're not going to automatically trust the government to provide health support and healthcare support. So I think that there's, it's all very interconnected, and I think it's sort of difficult when the narrative is, oh, these groups are so hard to reach or they're so resistant. I think that really puts the blame or the onus onto groups that when really we should be trying to use more diverse spokespeople, much more community engagement, more research that actually understands what people need and want to hear, and then providing that rather than assuming that sort of one overarching message is going to just automatically reach everyone. And I think that's really where we're at this point with the communication, is that it just has to be more targeted and tailored.
Are they giving you funding to do that?
We're getting a bit of funding from the Victorian government to do the training. Yes, there is a lot of work that could be done that I think in all the states that everyone's really looking for additional funding for.
We all know that it's not vaccines that's the solution, but vaccination. Paul, we get asked a lot, what level of vaccine uptake do we need to achieve? And I wondered if you've got your best answer ready to give. and maybe Jessica would like to comment on that as well. After you.
I guess my response to that is that there's no simple number. There are so many variables that contribute there, but what we should be aiming for is just as high as possible. I mean, we know these vaccines work, that, they're almost 100% at preventing severe disease. They help with symptomatic infection. And even though it was argued for a long time, they do help with transmission, although obviously to a lesser extent. But the key here is just getting as many as we can. I don't think we should draw a line in the sand and relax when we get to that point. I think we need to aim for as high as we can, because there's just so many variables that, it's impossible to have a simple number, is my answer.
Jess, you want to add?
I just say that I think the communications challenges around this will be ongoing, because we, as you said, we need to get as many people as vaccinated as possible. We also may need to get people vaccinated multiple times, having boosters. We may need to be targeting children with, a vaccine in the future. So the sort of challenges and the opportunities from a communication standpoint and from building confidence and acceptance will just continue. We're not going to reach some mythical target and then be done.
Okay, thanks. Dominic, what do you think the key issues are right now? Obviously, we want to know your secrets from your meeting that you had to go to. So what should we all be doing in our different ways to promote the prevention of this disease?
Well, yeah, look, how much time have we got? But look, I guess there's a couple of things. And again, one point that I like to make for an audience like this too, and I'm sure we all give talks to various sort of craft groups in medicine and nursing and general health. I think there's a really strong responsibility for individuals as well, in our line of work, to promote vaccination. And sure, you can put ads on TV and you can have pictures of, ScoMo getting a vaccine. That's all well and good. But I think there's tremendous advantage, and it's a lot of work, in each of us taking a role in telling people, family, friends, all of that sort of stuff about vaccination and answering the questions. I don't know the science at all, but I think there is a sort of ripple out effect of good communication by healthcare professionals to their patients, to their contacts, to their friends and so on. And if you can, persuade one member of a family who's a bit hesitant about things that this is all fine, not only hopefully do they get vaccinated, but then so does the rest of their contacts and so on. So this ripple out effect, I think, is really important. And I think we actually have quite a responsibility of doing that, both in the clinical, in the clinics and talks and so on. But it is time consuming. So I think that's particularly effective in the vaccine hesitancy group. Anyway, I won't go into all the other things that I think are important, but that's just one thing that we as a group here on this forum should be focusing on ourselves.
I'm interested, Dominic, whether the validity, the reliability of the results, are they all, in terms of sensitivity and specificity, when we're using NAT, are they all 99% and above? I'm not talking about the antigen or antibody tests. I'm talking about the nucleic acid.
The PCR tests are all extremely good, and there's certainly a step up over the rapid antigen test, as we know. And we've been through this debate in the ISG for years about rapid antigen tests for flu and RSV and so on. To me, the key is how common is the disease in the community as to how to use these assays. So, in the situation we have been in Australia, we clearly want high sensitivity and specificity. And the PCRs do offer that. Sure, there's occasional issues, and we see, but they can be addressed. In a high prevalence environment where the disease is rampant, then the rapid antigen test, the lack of sensitivity and specificity is perhaps less significant. The other key thing I think about the PCR tests is that in Australia they're all linked to notification systems, so that for example, our lab downloads electronically immediately a positive result is available, meaning then that the public health folk can go and act on that immediately. And that's why I think that's a real plus in the system. The rapid antigen tests and so on that are not integrated into laboratory systems or the public health system are really problematic. And this has been described in the US with their widespread use of rapid antigen, even rapid PCR tests, unconnected to laboratory information systems or public health systems. So I've been very confident anyway with the performance of the PCR tests for this, bearing in mind the caveats around any laboratory test.
Paul, there's quite a few questions around heterologous, meaning having one vaccine first and a different one second time. Questions about the degree of protection after one dose of AstraZeneca. When does the protection after the second dose kick in? Could you field a couple of those questions for us?
Yeah, of course. I think that the key right now is that how we use these vaccines is continuing to evolve as the virus does and our information about how the vaccines work. So my simple advice is to follow the recommendations at the time. In terms of heterologous boosting, I think we're seeing some very promising results emerge from a number of studies, and of course some countries have already adopted that strategy. As with a lot of these things, the increased response perhaps comes at a trade-off of slightly increased reactogenicity. So I think it is something that's going to be a big part of our strategy moving forward. Yeah, I think it's important, as I say, to follow the advice at the time. And it's very clear that right now we're recommending people have the same second dose as the vaccine they had their first dose. And of course, a lot of people are discussing their concerns around AstraZeneca and the rare TTS or clotting issue that we've heard about does happen almost exclusively with the first dose. So that's why our advice at the moment is very clear to get the same second dose. But as I say, when the information is sufficient to recommend a change, that'll obviously be communicated, and we should all adopt that at that point in time. In terms of first dose versus second dose protection, again, it's hard to give a simple number because there are just so many variables. It depends on which study, which variant, and in which population, to name but a few. I think what's clear is that the second dose is very important for the variants of concern we're discussing so much at the moment. So, again, I'd make sure people get their second dose at the recommended time interval, although there is some flexibility around that. And in terms of when the protection is present or peaks, again, it's a little bit of a spectrum, but we do know in the weeks following the second dose that the protection that we're hearing about so much in terms of those numbers that are quoted for efficacy comes into play. So, and simple thing there is both of the vaccines we're relying on in this country at the moment are highly efficacious, even against those new variants, particularly if the second dose is given.
Brilliant. Jessica, you got time in all the other things you're doing to develop some teaching materials for healthcare workers, and you said that only 27% of people had enough information. So how are you leading the charge in remedying that problem?
One step at a time. So basically, we developed, like I said, on behalf of the Victorian government, we put together a training package that is essentially, how to build vaccine confidence. So it starts with information about the vaccine, sort of answering questions. It's very interactive, and I think one of the keys Dominic was mentioning, answering people's questions, not just providing something that is static, not just an FAQ fact sheet, but actually letting people ask questions and responding to those in an interpersonal conversation makes a really big difference. So we spend a lot of time on that. And then we speak about sort of empowering vaccine champions. And that's, again, where anyone can sort of be a vaccine champion. And that's having willingness to have those conversations with your friends and your family, being very open-minded and non-judgmental, so that people don't feel like you're going to judge them if they, have concerns, and they're not going to be labeled an anti-vaxxer. And then the sort of third section of the training is all about those, how to have an effective conversation with someone who has concerns. And that's based on lots of research that's been done with childhood vaccination conversations, and also some research around promoting maternal vaccines, and sort of how to break down a conversation so that, again, you're not, you're responding to people's concerns, you're not turning them off or scaring them away from asking questions. So we deliver that in basically to all different groups: industry leaders, faith leaders, community leaders, different healthcare worker groups. But it does take time, and it does take outreach, and it takes, coordination to put these sessions together. On some level, the Zoom environment has been helpful for that. It does mean that you can reach more people more quickly than if you were going into lots of communities, but I think it's going to be ongoing. And the idea really would be to train up enough people who don't necessarily have clinical background or research background, but at least feel confident in promoting the vaccines and answering some questions about the vaccines, so that you get a whole army of vaccine champions who can help address people's questions. Because there's a single campaign is not going to answer everyone's concern, but it is a big investment of funding, energy, time, and sort of emotional labor, even just to have these kinds of conversations repeatedly. But I think that's what's going to get us over the line, if anything does.
Well, we're on a precipice right now of potential magnification of the problem throughout Australia. One of my favourite questions and issues is early diagnosis and early treatment. And I wondered if you could field both of those in a general sense, Dominic. The early diagnosis potentially with nucleic acid technology in point of care in nursing homes, for example. Is any point of care being done as part of New South Wales pathology? And which drugs should be used early by GPs, and which should be used in ED, and what should be used on the ward and in the intensive care, but especially the earlier treatments?
Well, look, I think, I mean, I'm certainly happy to comment on the early diagnostics. I think that's really fundamentally important. And I think that, you know, there has been state variation in, well, not state variation, but certainly international variation in the use of testing early in the piece. And I think, you know, without, you know, being difficult, the approach in Australia was to offer kind of widespread testing aggressively. And I think in terms of then following up for public health purposes, the linkage between the labs and the public health was really important. We certainly saw in other countries, particularly in, well, you know, my experience in Europe, where testing was limited to people with severe disease, plus shortages, you know, and so on. So by the time they kind of realized something was going on, it had well and truly escaped everybody. So anyway, the point of all of that is to say that early diagnostic testing is crucial, low index of suspicion, using the right tests, making testing available as easily as possible, you know, community testing centres, all of that sort of thing, rolling those out. I agree with your point about nursing homes. I think that's particularly important, not just for SARS-CoV-2, but indeed for influenza and RSV and many other respiratory viruses. So the sort of mobile laboratory approach, I think, is a very good one. You know, it's, as we know, it's hard to get funding for that sort of stuff. But I would have thought that rapid testing in nursing homes and other closed environments, prisons, boarding schools, etc., super important, and as well as the community testing. So anyway, I can't believe that anyone would disagree with any of that. I think that's been generally the Australian viewpoint. We do have special groups that are hard to get to. So, for example, rural Indigenous populations and the approach to testing there, I think, is really important. Again, in New South Wales, we've had this centrally managed gene expert system for a couple of years. So it's actually pretty good in terms of its coverage and so on. And that's allowed, for example, rapid investigation of potential cases in some of our rural locations. So anyway, I think that's the approach. As for treatment, look, I would defer, personally, I'd defer to people who deal more with patients. I don't deal with patients in intensive care, so the approach there, but you know, certainly they're quite detailed guidelines. I know the American Infectious Diseases Society and some of those groups have very detailed recommendations about what treatments to use. The SARS antibody, monoclonal antibodies, and so on, have promise in you know, certain clinical situations, in early clinical situations prior to people going, you know, ending up on a ventilator. There's a cost implication with those, of course, which is problematic in their availability in Australia. Steroid use and other immune modulators in more severe disease, again, you know, has a role, but with their own complications. So I think at this stage, perhaps unlike flu, influenza, here the sort of approach is rapid, early, you know, available and early testing, with then public health messaging and interventions such as quarantine and training about home hygiene, etc., are actually the key messages here. We don't have an easy treatment pipeline.
Okay, we're running out of time. What I'd like to do is invite all three of you to look at the Q&A and choose the question you'd most like to answer that hasn't already been answered. But I'd also like, before we move on to each of you choosing your own Q&A to answer, your own question to answer, is to see if Paul wants to add anything to the treatment discussion.
I guess just to say that our lack of a, you know, specific highly effective antiviral really highlights why prevention is so important and why we do need to focus on, maximising the use of the vaccines that we do have available. I mean, I suspect we'll have some antivirals at some point in time, and use of things like antibodies and more novel immunomodulators will probably become more commonplace. But again, right now we're still lacking in some of those things. So again, I think it's a useful point to highlight the importance of vaccination.
Brilliant. So, Jessica, have you chosen your favoured question to answer?
Sure. Someone asked about whether we explored political factors that might be impacting on people's awareness or on their response to the vaccine rollout. We didn't specifically explore this in our research, although when we asked people sort of about spokespeople and where they got information, we did get a very clear sense that many people really trusted public health professionals. So Brett Sutton and Alan Chang in Victoria were named as people that they felt were trustworthy and gave good information. But there was sort of a real disconnect between that and more politicians. And so people mentioned that watching, for instance, Scott Morrison or Julia Gillard get vaccinated was not nearly as influential to them as if they saw, like I was saying, real people or people that they felt were much more like themselves. And I guess I would just also say that really there's no winner in promoting vaccines when it becomes politicized, because the media headlines become much more inflammatory. There's point scoring. There's things that sort of just muddy the waters of just trying to explain the vaccines and promote the vaccines. And we've really seen sort of the downsides of politicization in America, where 30% of people, mostly Republicans, will not get the vaccine purely because it has been politicized to that extent. And that becomes a whole other challenge to overcome that's tied up with so many other values and challenges. So that's my final response, I suppose.
Brilliant, thanks. Dom?
Thanks, Robert. Look, there's an interesting question there from, it's anonymous, but around how laboratory results can also ask for or advise about vaccination. So the question is that can we improve vaccine uptake by laboratories providing a result to the patient with a suggestion about vaccination, so that, again, this has been one of the features of this current pandemic, in now that laboratories are providing a text message directly back to patients with their COVID-19 result, which is fantastic. And then if you stick in a message about, oh, well, don't forget to get your flu shot or your COVID-19 shot, then I think that's a really interesting way of doing it, and it's direct and personal to the patient. So I think that's a great idea, and the whole desire to push results directly back to patients rather than through doctors has sort of moved a lot in the last year or so, and I think that's interesting. There are problems with it, don't get me wrong, but I think it's a very interesting way, particularly if the results are negative. If you get, most of the COVID testing we're doing negative, so great, you get a result, you feel good because you've got a negative result on your phone, and then someone gives you a nudge about vaccination. Fantastic. A little bit more complicated if the test is positive, but that's another whole discussion. So
cool. Paul?
I think all of my questions have been answered, and I think we're at time, so I'll skip mine unless there's something else for me. Thanks.
Okay, well, look, thanks everyone. It's been a superb session, and I'm glad we got over the technical problems. That's always the case with Zoom. So it's time for about a quarter of an hour break or so. So I can finally have my breakfast and you can have your cup of coffee. Thanks, guys. Thank you all very, very much. Thank you.
Thank you.